Good morning from Canada, ladies and gentlemen, because I know some of your places will be evening, some will be at night time. So Thyroid Federation International welcomes you across the globe for joining in the webinar. We have people from Australia, Japan, Philippines, Nepal, India, Africa, Europe, Canada, USA, Brazil, and I have two of my classmates, Niranjan and Sudhakar on the line. Thank you guys for joining. This is great to have my classmates also on this. So you all are welcome to the 13th International Thyroid Awareness Week. Due to the pandemic, this is the second year in a row that we are doing online celebrations for the week. Now, before I proceed, I wanted to thank our supporters for International Thyroid Awareness Week 2021 for the support to hold a webinar today. I would like to thank Merck KGaA Germany, Horizon Pharma USA, Exelixis USA, and Porter Novelli for hosting this seminar today. My name is Ashok Basi. I'm president of Thyroid Federation of International, and I would be a facilitator for the webinar today. Thanks to Dr. Leonidas Duntas, whom I should introduce shortly. Leonidas, thank you for all the hard work that you have put in. You know, actually, I was just thinking about it the other day. My heart goes out to endocrinologists like you, a lot of others that I have around the world, you know, who take this effort and time from family time and prepare everything. And, you know, they don't even charge any fee, nothing. And in your case, you gave 500 euros to us as a gift to Thyroid Federation instead of taking it. So thank you so much. You know, guys like you make a big difference in our lives. Professor Duntas he's done internal medicine and endocrinology at the University of Ulm, Germany, and clinical and research associate at the University or two in endocrinology, diabetes, and metabolism from University of Athens, Greece. Today he's speaking from Athens, Greece. After obtaining his medical degree at the University of Bologna, Italy, he specialized in internal medicine and endocrinology at the University of Ulm. His main research interest is clinical thyroidology, in particular, the influence of environment, especially as regards to selenium on thyroid function and disease and thyroid cancer. He has served as an elected member of the Executive Committee of the European Thyroid Association. He currently chairs the Educational Board, and he is member of the Public Health Board of ETA and the Public Health Committees of the American Thyroid Association. He is also visiting professor at the University of Beograd and Novi Sad, Serbia. Professor Leonidas is an active member of the ETA, that is European Thyroid Association, American Thyroid Association, the Hellenic Endocrine Association, the German Society of Endocrinology, and the German Society of Internal Medicine. He is the author of numerous peer-reviewed original articles and reviews in renowned journals and textbooks. He is associate editor of Thyroid, the official journal of American Thyroid Association, and of Hormones, the journal of Hellenic Endocrine Society. He serves on several editorial boards, among these that of Journal of Endocrinology Investigation, where he is additionally a regular reviewer for a number of international journals. Isn't it delightful to have a friend like you, Professor Leonidas, you know, who has taken the time to come today, and so many rehearsals also that we did, and share your knowledge with us. Thank you very much for joining. I'll hand it over to you with any further ado.
Thank you very much, Ashok, for this introduction. Good morning, ladies and gentlemen, or good afternoon or good evening, depending on where you are. So I'm Leonidas Duntas, Professor of Endocrinology at the Viennedian Hospital, University of Athens, and I warmly welcome you all to this presentation organized by the Thyroid Federation International on the occasion of World Thyroid Day and International Thyroid Awareness Week. I'm very pleased to be with you today, though things will be so much better if this lecture will be done in person. We hope this will be the case before long. I would like to cordially thank Ashok Basin, President of TFI, and his team, particularly Peter Ludwig, for the invitation, and heartily congratulate them on achieving the aims of TFI. The European Thyroid Association has traditionally supported and promoted the TFI, which merits our utmost esteem for all that the organization has accomplished over the decades for the care of thyroid patients. It is also my pleasure to convey warm greetings from the members of the ETA Executive Committee to the leadership and members of the TFI. World Thyroid Day, 25th of May, was established in 2008 by the ETA and the sister associations, as well as by the TFI, and since then has yearly been increasingly commemorated around the world. World Thyroid Day and International Thyroid Awareness Week are dedicated to the millions of patients with thyroid disorders worldwide. The aim of this commemorative day is to increase awareness about thyroid disease and provide education on this vital health issue, while, importantly, calling upon the authorities to increase resources for research to upgrade treatment of thyroid diseases, as well as to support such initiatives as the European Commission's chemicals strategy towards a toxic-free environment, November 2020, all with the aim of enhancing our patients' quality of life. It is a day for us all to get more closely connected, with a commitment to stay connected throughout the year. We're now going to review some data on the importance of iodine for the thyroid and on several key aspects of iodine supplementation, while we will also briefly go over the associations of COVID-19 with thyroid function and disease. Starting off with Benjamin Franklin's famous words, "Teach me and I remember, involve me and I learn," I kindly ask you to actively participate in this presentation by first listening to what I have to say, then providing your own input to our discussion. Iodine deficiency is still a global problem, as you can see on this map, even though improvements have been made thanks to the impressive efforts of the Iodine Global Network and the TFI, together with the support of the international sister associations, namely ATA, Asia, Oceania Thyroid Association, Latin America Thyroid Associations, and ETA. There are still severely iodine deficient areas in various parts of the world. The climate crisis, involving, among others, increasing flooding, deforestation, and soil erosion, are amplifying the problems of iodine deficiency. The term iodine deficiency disorders recognizes a spectrum of related disorders potentially affecting about 2 billion individuals. Iodine deficiency induced pathological conditions and diseases can present throughout the human lifespan, as is depicted in this table, in fetus, neonate, child and adolescent, adult, and in all ages. The most established method to correct iodine deficiency is iodine supplementation through salt iodization. It is a convenient and cheap method adding iodine to the salt. Alternative, administration of iodized oil capsules taken every 6 to 18 months, or direct administration of iodine solutions, such as Lugol's iodine, at regular intervals once a month. Iodization of water supplies by direct addition of iodine solution or via special delivery system. Salt iodization is today the method of choice when you consider the positive global results from salt iodization programs at percent of households consuming iodized salt. You see that a large amount of households using iodized salt around the world. But why iodine is so important for the thyroid? Well, we know that hypothalamus, in the center of the brain, secreting a peptide called thyrotropin releasing hormone, stimulates pituitary gland to secrete TSH, which TSH stimulates thyroid to secrete thyroxine, the main thyroid hormone, which may have a negative impact on the secretion of TSH and TRH. This is a feedback mechanism, very important for the homeostasis of thyroid function. So thyroxine and the active triiodothyronine, which is converted from thyroxine, are the two main thyroid hormones, and they include iodine. Thyroxine is called T4. Why? Because it has 4 atoms of iodine, while T3 has in its structure 3 atoms of iodine. So the main thyroid hormones are depending on iodine availability. And the synthetic form of thyroxine, levothyroxine, is according to the American and the European Thyroid Associations, the frontline treatment of hypothyroidism. Iodine absorption and metabolism. This is here some important information. Iodine is rapidly and nearly completely absorbed in the stomach and duodenum. Iodate, widely used in salt iodization, is reduced in the gut and absorbed as iodide. In conditions of adequate iodine supply, no more than 10% of absorbed iodine is taken up by the thyroid. In chronic iodine deficiency, this fraction can exceed 80%. During lactation, the mammary gland concentrates iodine and secretes it into breast milk to provide for the newborn. Iodine in the blood is turned over rapidly with a half-life of approximately 10 hours, which is shortened if the thyroid is overactive, as in iodine deficiency or hyperthyroidism. The body of a healthy adult contains 15 to 20 milligrams of iodine, of which 70 to 80% is in the thyroid. In chronic iodine deficiency, the iodine content of the thyroid may fall below 20 milligrams. The organification, coupling, and storage, release of iodine. We have the several processes leading to the formation of thyroxine. It is important, the oxidation and the organification of iodine and coupling to iodotyrosines in thyroglobulin. And this coupling is dependent on an enzyme called the thyroid peroxidase. The coupling of thyroglobulin is taken back into the thyroid cell. The procession in lysosomes release T4 and T3. And here, schematically presented what we have said before. You see that iodine is entered through the natrium iodine importer, and is oxidized, iodinated, and conjugated to thyroglobulin, which via endocytosis process, followed by proteolysis, leading to thyroxine thioethylthyronine formation, and then the secretion of the hormones into the blood. The prevention of simple goiter in man was succeeded first time in 1917, as Marine and Kibel showed that goiter was caused by iodine deficiency and could be prevented by iodine supplementation. Goiter prophylaxis through salt iodization was first introduced in Switzerland and the United States in the early 20s. In mild to moderate iodine deficiency, increased thyroid activity can compensate for low iodine intake and maintain euthyroidism, but at a price. Chronic thyroid stimulation results in an increase in the prevalence of toxic nodular goiter and hyperthyroidism in population. This high prevalence of nodular autonomy usually results in a further increase in the prevalence of hyperthyroidism. If iodine intake is subsequently increased by salt iodization. However, this increase is transient because iodine sufficiency normalizes thyroid activity, which in the long term reduces nodular autonomy. Increased iodine intake in iodine deficient areas is associated with a small increase in the prevalence of subclinical hypothyroidism and thyroid autoimmunity. Whether this increases as also transient is not clear. This large nodular goiter was found in a 14-year-old boy in 2004 in an area with severe iodine deficiency disorder in northern Morocco, and with tracheal and esophageal compression and hoarseness, with damage to the recurrent laryngeal nerves. This is a very rare situation. Now we do not see such cases around easily around the world, but this is the consequences of a long-term iodine deficit. So we said that increased iodine intake in an iodine deficient population might be associated with a small increase in the prevalence of subclinical hypothyroidism and thyroid autoimmunity. But these are transitory situations. It is important that to counteract the iodine deficiency, because if it remains, it may chronically result in an increase in the prevalence of toxic nodular goiter and hyperthyroidism, or in big, very large goiters, as we saw in the patient before. In the general population, a median urine iodine excretion of 100 to 199 reflects adequate iodine intake, while a median urine iodine excretion of above 300 indicates excessive iodine intake. In pregnancy, the situation is slightly different. An adequate iodine intake is assured. It should be assured by an iodine excretion of 150 to 250 micrograms a liter. 250 up to 500, it indicates that the iodine intake is more than adequate, and above 500, that the intake is excessive. Breastfeeding women should have an adequate iodine, having a median iodine excretion of above 100 micrograms a liter. But if the iodine intake is in excess, we may have some problems. Excuse me here. So they have in Denmark some areas where iodine severely iodine deficient. They have organized iodized supplementation of salt. They have iodized the population, and they have performed a study some years after the iodization. Here we have the map of Denmark, and the yellow spots indicating iodine excretion of 40 to 80 per 24 hours, and it was in a part of population amounted to 2.9 million, and the red 80 to 100, and the black, this is the area around Copenhagen, 120 to 170. The study was performed by the group of the late Peter Laurbeck, and was published in 2006. And they have seen 5 years after the iodization that the prevalence of TPO and TG antibodies in the before and after the fortification of with iodine, it was much and significantly statistically significant different than before. So we had an increase in thyroid autoimmunity, indicated by the increase of thyroid antibodies, both against the thyroid peroxidase and against thyroglobulin. Similar results have been found in a study conducted in China by Weibing Teng and published in 2006. And here they have examined the population of 3 areas, one with very low iodine intake, one with moderate, and one with high iodine intake in Huanghua. And you can here see that the thyroid peroxidase antibody levels were higher, the highest in the area of increase of excessive iodine intake as compared to the moderate to the low iodine intake. And the same was for the thyroglobulin antibody levels. And similarly, in another more recent study conducted in 10 cities, 6 had a low iodine intake, and 4 cities here in the eastern part of China had a moderate to excessive iodine intake. And again, here you can see that the incidence of goiter, the incidence of nodules, the incidence of overt hypothyroidism and subclinical hypothyroidism were higher, depending on the city and depending on iodine intake. So how can we take iodine? How can we expose to iodine? Of course, via nutrients, iodine salt, seaweed, seafood, bread, drugs, and other sources as food preservatives, expectorants, vitamins and supplements, mouthwashes, toothpastes, may have a considerable iodine amount. Very important, and I would like to here talk to you that this Wolff-Chaikoff effect, this is the proposed mechanism for the acute Wolff-Chaikoff effect, the mechanism by which adaptation to the acute Wolff-Chaikoff effect occurs. This is what happens when an excessive amount of iodine is taken. Well, this effect was described in 1948 by Drs. Jan Wolff and Israel Chaikoff at the University of California. They observed a transient reduction lasting about 24 hours in the synthesis of thyroid hormones in rats exposed to high amounts of iodine administered intraperitoneally. The mechanism for this acute Wolff-Chaikoff effect is not completely understood as yet, but is thought to be at least partially explained by the generation of several inhibitory substances on thyroid peroxidase activity. The proposed mechanism for the acute Wolff-Chaikoff effect is that during initial iodine exposure, excess iodine is transported via the iodine symporter, sodium iodine symporter, into the thyroid gland. And this transport results in the transient inhibition of TPO, this enzyme we said before that is very important for the formation of thyroid hormones, and subsequently decrease in the synthesis of thyroid hormone. The mechanism by which adaptation, this is the part B now, to the acute Wolff-Chaikoff effect is a decrease in the expression of iodine, of sodium iodide symporter, resulting in a reduced iodide transport, which enables the synthesis of thyroid hormone to resume. So it blocks here when we have an excessive intake. Initially, we have an increase in thyroid hormone production, but following a couple of hours later, we have a block in this sodium iodine supporter and increase TPO activity so that the hormones can be resumed. The synthesis of hormone can be resumed. So we come to the first take-home message that iodine supplementation is imperative for prevention and treatment of iodine deficiency disorders. Supplementation should be maintained at a safe level, and supplementation programs should be tailored to its particular region. If it is iodine deficient, moderate, severely, or adequate. A normal iodine intake is associated with at least a partial adaptation to the excess iodine and escape from the acute Wolff-Chaikoff effect. The correlation between iodine intake and thyroid diseases has been described as a U-shaped curve, with optimal iodine intake overall being associated with a lower risk for abnormal thyroid function and or thyroid autoimmunity than either inadequate or excessive intake. As both excess and deficiency are associated with thyroid diseases, achievement of optimal iodine intake is should be our goal. While universal, short iodization has worldwide reduced the incidence of such iodine deficiency disorders as goiter, long-term exposure to excessive levels of iodine from underground water or inadequately monitored salt represent considerable risk factors for hypothyroidism. Here you see by low iodine intake, iodine deficiency. It is therefore evident that concerted efforts must be made to establish adequate and balanced levels of iodine intake in all countries, as even slight variation in this equilibrium has the potential to adversely affect the entire organism. In other words, the severity of any given disorder could well be proportional to the degree of iodine excess or deficiency. The second take-home message is that levels that are more than adequate, median urine iodine excretion 200 to 299 micrograms a liter, or excessive median urine iodine excretion above 300 micrograms a liter, or median above urinary iodine excretion above 500 micrograms a liter in pregnancy should be avoided, especially in populations susceptible for autoimmune thyroid disease. It must be again emphasized that the benefits of iodine supplementation, when and wherever is needed, clearly outweigh this risk, which may slowly be reduced over the years as the iodine replacement is installed. And we come now briefly to COVID-19 and thyroid. We know that COVID-19 is generated is induced by a virus called SARS-CoV-2, which binds to the receptor of angiotensin converting enzyme, which is enzyme important for the regulation of blood pressure, and these receptors are abundantly on the alveolar of the lungs, on the alveolar cells of the lungs, and here where the SARS is binding and enters into the cell, it releases its RNA, which hijack the cell and stressing to replicate its mRNA, so that the whole cell is taken over by the virus, is destroyed, and slowly all the lungs is destroyed, resulting in this severe acute respiratory syndrome. Some conditions and endocrine diseases may increase the mortality of COVID-19. For example, obesity may increase the mortality by 28%. Hypertension increases threefold the mortality, as well as diabetes mellitus. Thyroid is susceptible to COVID-19. Why? Because thyroid expresses abundantly the ACE2 receptors. And you see that it's abundantly in thyroid more than many other organs, and also more than the lungs. And via the interleukin-6, which is an inflammatory cytokine, and which may have an impact at the various levels, regulate the thyroid function. So it may have central effects by decreasing TRH and TSH pulsatility, the reduction of the production of thyroid hormones by disturbing the thyroxine body globulin and transthyretin, which are transporter proteins of thyroid hormones, increase the presence of inhibitors of thyroid binding to distribution proteins like bilirubin and indoxyl sulfate by in the liver, reducing the T4 to T3 tissue uptake, and also decreasing the conversion of T4 to T3, and also by direct action on deiodinases, which are enzymes that catalyze the conversion of T4 to T3. After having seen some of the mechanisms which are implicated in the induction of thyroid disorder caused by SARS-CoV-2 infection, we come to see a couple of cases of some thyroid diseases induced by COVID-19. The first was a case of subacute thyroiditis, which was published in 1 year ago by Alessandro Bracantella from Pisa. The patient was an 18-year-old woman who presented for fever, neck pain, radiated to the joint, palpitations, occurring 15 days after SARS-CoV-2 positive oropharyngeal swab. That was the first case, and the symptomatology was very mild, and also the patient completely recovered in a few days. Here you can see the laboratory findings of this patient, and by entrance, the free T4 and T3 were higher, much higher than in February 21. Here we have the reference ranges, but about 10-12 days later, they normalized. As well, the TSH was clearly suppressed in a hyperthyroid level. It was normalized in April 1st. So it was a transitory hyperthyroid phase induced by COVID-19. This was the first the patient with so-called subacute thyroiditis induced by COVID-19 published. Interesting to refer that povidone iodine oronasal spray, which includes polyvinyl pyrrolidone or povidone iodine, was effectively tried in patients to protect patients from COVID-19. So you see that iodine may also have a protective effect on COVID-19. And here, now we have a very interesting study from Milano The authors have looked in about 100 patients coming to the clinic with COVID, and they were admitted to the high intensive care unit. And they compare the TSH values and the CRP, which is an indicator of inflammation in these patients, as compared to those who were admitted a year earlier, and those who were admitted on the low intensive care unit of lower care intensive care unit. And you see that those who were admitted in 2020 with COVID-19 had the lowest level of TSH and the highest level in CRP. These patients presented initially a high FT4 and low T3 and TSH. If they could go out of the clinic, these results were partially reversed. And the authors propose that T3 might be an indicator of disease outcome. So we have this COVID-19 related atypical thyroiditis, a higher prevalence synthesized here that a high prevalence of thyrotoxicosis suggestive for subacute thyroiditis has been reported in patients admitted to high intensity of care units in relation to the presence or absence of COVID-19. Therefore, a routine assessment of thyroid function in patients with COVID-19 requiring high intensity care is suggested. Very interesting to show you this slide showing that the vitamin D levels before COVID-19 were in all the quartiles of vitamin D levels lower in those who were positive in the COVID-19 as compared to those who were negative. So, if patients have COVID-19, test positive, they showed low levels of vitamin D. And what is the meaning? What does it mean having a low vitamin D levels? We know that vitamin D is an important factor for the autoimmune syndrome. We know that all the inflammatory diseases are accompanied by low vitamin D levels, and it is the mechanism might be that this is an interesting figure showing that inactivation of envelope viruses is stimulated by vitamin D and blocked by air pollution. You know that vitamin D is increased from sunlight and from supplements and food. The active form of vitamin D, 1.25, binds to the vitamin D receptor, which stimulates the transcription of cathelicidin gene. Cathelicidin is cleaved to generate a cation antimicrobial peptide, this LL37, which binds and disables the envelope of viruses. The air pollution, this is very interesting, that the air pollution inactivates this cation peptide by removing the charge and leaving viruses to replicate unimpeded. This is a mechanism which should be recorded when we think that vitamin D is low in patients with COVID, and this might be an explanation why in some cities we have such a high amount of COVID-19 cases, for example, in Mexico City, in New Delhi, partially in London and some areas in New York. The air pollution might be an influential factor. Excuse me here, let's we come now to the conclusions regarding COVID and thyroid. Thyroid is exposed to SARS-CoV-2. Subacute thyroiditis may be uncounted in patients with COVID-19. Therefore, increased awareness is needed for timely treatment of patients. Patients with hyperthyroidism may be more susceptible to adverse outcome of COVID-19 due to the regulatory influence of thyroid hormones on the coagulatory mechanism and on the cardiovascular system. Vitamin D3 levels should be checked regularly, and if low, substitution should be initiated as a prophylactic and therapeutic modality. Chronic unsatisfactorily treated hypothyroid patients with developing arterial hypertension and obesity are at a higher risk of COVID-19 and of worse prognosis. Appropriate treatment of hypothyroidism and, if necessary, of the comorbidities is highly recommended. So, and now we are at the end of this presentation, and I would like to thank you very much for joining us and for your attention. And I'm turn off the microphone to Ashok Basi. Thank you.
Thank you very much, Leonidas. That was excellent. And to see the effect of air pollution also on COVID, and that is something very interesting to note. I haven't heard of that one before, but really, really nice. And thank you for this beautiful picture of Greece. We want to be there. And we promise you, as this is over, we will have a meeting in Athens, Greece.
It will be much better to be here now than on via this cold screen.
That is true. That is so true. Nothing like having an in-person meeting. Just a shout out to all the people around the globe who have joined us. From Brazil, we have Dr. Volpi also there. He's an eminent surgeon in endocrinology. And then from Indonesia also we have our physician friends. From Finland also we have. But I wanted to shout out to everybody: Mexico, Australia, Bulgaria, France, Finland, Greece, Sweden, Spain, Italy, Indonesia, UK, India, Nepal, USA, Brazil, Kenya, Ghana, Nigeria, and Canada for all to join us today. And friends, this will also be available on YouTube in the future. So before we go further, I have two more things. One, two questions are there for you, and you can tell us as short as possible because we are running out of time. And the second thing is, I have to thank all of the people who made this possible. So just one question is, I am a hypothyroid patient. COVID-19 has been severe. What do you recommend if me or anybody like myself with the thyroid condition, like hypothyroid they have, was to get infected with the virus? Am I at higher risk with COVID-19?
Depending on what kind of hypothyroidism. Is hypothyroidism induced by autoimmunity or is induced by chronic exposure to iodine deficiency? Anyway, you should check the thyroid. And of course, if you are hypothyroid, you should take, or you should regularly take your thyroid hormone. You should take levothyroxine. It has been a study showing that those who are hypothyroid and got the virus, they are exposed at the worst outcome of COVID-19. So it means that, and this is a very strong suggestion to all our patients, to check the thyroid and control your thyroid, take regularly the tablets. If you are well controlled and if thyroid is excellently regulated with levothyroxine, you are not more exposed than the other people. But if you are not well controlled, then potentially you are more exposed. Although there are no studies showing that those who are not controlled and those who are severely hypothyroid are much more exposed. It depends on our self-defense mechanism, on our immune system, how well our immune system is to counteract and to tackle COVID-19.
Thank you so much. Thank you so much. We are running out of time, so we can't take more questions for now. But again, I would like to thank you, Leonidas, for taking the time and all the efforts you put into this. And you made it happen. It takes a lot of time away from family to do this. We really appreciate this. And I also wanted to once again thank Exelixis USA, Horizon Pharma in US, and Merck KGaA for the support on the International Thyroid Awareness Week. Today is the last day of the International Thyroid Week. That is the closing date, 31st of May. And thank you so much again for taking the time to do this. I also wanted to thank Porto Novelli for putting this up and also making sure that it will be available for our YouTube presentation after edits that has to be done. I wanted to thank TFI board, Beata, Nancy, Linda, Peter, and invited members at large, Marco, for all the hard work on the WebEx support and putting the lectures together. It takes a lot of time. We are volunteers, and I really appreciate all of them to put this together and, taking the time and input to make this happen. Thank you very much.
Ashok, excuse me. I see that there are some questions coming in. Please allow me after that, after we leave, allow me with your technical stuff that I can reply by writing the email to the questions. Because I see that there have been some questions coming in now, that also regarding vitamin D, etc. So after that, I can reply. Give me the questions, and I will reply to them.
Yeah, but we have time for one more question. If you can go.
Okay. I thought that we were done. Okay.
Yeah.
Please, I am here. No, there is no problem. For me, there is no problem. I'm here. I'm here for you today. This is the last day of the week, of the Awareness Week. So I'm here. I'm very pleased to be with you.
Okay, so one more question is there. What precautions will you recommend for expectant mothers who are delivering baby in 1 or 2 months at the hospital?
Again, first of all, check the thyroid. If thyroid is well controlled, adequate iodine intake, adequate iron intake, and selenium intake, which is also very important for the duration and the outcome of pregnancy, and regularly control the thyroid hormones and TSH in every trimester, depending on the area where the patient is located. Is an iodine deficient area, moderate, adequate, excessive iodine area, but thyroid control is imperative. And then nutritional factors, I repeat, like iodine and selenium and vitamin B12 and iron should be taken with care.
Thank you so much. I think with that, if there are any more, I will send it to you.
Okay.
And we can put that up on the YouTube. Thank you so much again, and it's almost an hour now. So we will say goodbye to everybody from Australia to Brazil, and thank you for joining us. Wish you all the very best. Thank you, and bye for now.
Bye-bye to everybody, and Ashok, thank you too. All the best.
Thank you.
All the best. Bye. Bye.
Bye-bye.
Bye.